Assalamu alaikum. My name is Omar Ahmad, and today I'll be giving you guys a session on the renal pharmacology. So we have four different topics we're going to be talking about today: diuretics, immunosuppressants, benign and malignant prostatic diseases, and dose adjustments. So I'm going to go into slideshow in a bit, but for now I just want to keep it like this. You'll see why. So first topic was diuretics. Diuretics are one of the most important topics in terms of pharmacology in the whole of med because multiple different specialties will be affected by diuretics, multiple different systems in terms of side effects as well. Okay, you will always be seeing someone with diuretics. It's going to come back and over again in fourth, fifth year, as well as all of your board exams. So you really want to concentrate on everything in diuretics. Okay. So I created a table. We have multiple different drugs. Of course, I'm going to show you some diagrams as well, so you can get to understand it. Okay. First thing we have is carbonic anhydrase inhibitors. Just remember these terms so I can show you the figure. We have these acetazolamide, mannitol, loop diuretics, thiazides, and then potassium-sparing diuretics. Okay. So here's a nice figure, just where it's also a mnemonic, 2-in-1, where you can see everything and where it works. Okay. So first you need to understand the physiology of the loop, the renal tubules before you understand pharmacology. So you have the proximal tubule, convolute tubule, the descending and ascending lobe of Henle, distal convolute tubule, and collecting duct. Okay. Most of the things are initially absorbed here. Then you have some other things that are absorbed as you go on. So mannitol mainly works on the proximal convolute tubule as well as sometimes the descending lobe of Henle. Okay, if you can see my mouse here. Acetazolamide on the proximal convoluted tubule. Okay, loop diuretics ascending loop of Henle. Thiazides on the distal convoluted tubule, and then you have spironolactone as well as the other potassium-sparing diuretics here working on the collecting duct. Okay, now I can easily ask you a question saying, "Oh, where does a certain diuretic work in the kidney?" Okay, it's easy question. It's always going to come. So now that you have this in your mind, okay, let's look at the different mechanisms of actions and side effects. So you have carbonic anhydrase inhibitors. It's going to inhibit carbonic anhydrase, easy, in the proximal tubule. As a result, you're going to have decreased bicarbonate production. If you have decreased bicarbonate absorption, it's going to lead to excretion of bicarbonate. So it's not really used as a diuretic, okay, in terms of, oh, like I want to lose some water. It's not really used like that anymore. It's mainly used in glaucoma, altitude sickness, and metabolic alkalosis. If you think about it, why is it used in metabolic alkalosis? Because it's literally kicking out bicarbonate, okay? Glaucoma and altitude sickness. So glaucoma, you'll learn about that later when you take ophtha, if you haven't already. Altitude sickness, I don't think anyone really knows why acetazolamide can help in altitude sickness. Now, if you think about it, okay, if it's going to kick out bicarbonate, what is that going to lead to? It's going to lead to metabolic acidosis, isn't that? Because you're kicking out bicarbonate. You need bicarbonate to keep the pH level. If you kick out bicarbonate, it's going to lead to metabolic acidosis. How can you remember that? Instead of saying acetazolamide, I can call it, let's write it down, acid azolamide. Why? Because I'm making it more acidic. So acetazolamide is going to make it more acidic. How? By kicking out bicarbonate. Okay. So we're done with this with acetazolamide. We'll talk about it. We'll talk about more questions a bit later. Okay. I'm just going to give you a quick overview. Second, you have osmotic diuretics, mannitol. So mannitol, it's not really inhibiting like receptors or enzymes or something. Just mannitol is like a substance that increases osmolarity. So it's hyperosmolar, it increases osmolarity of plasma and tubular fluid. And just the law of osmosis is that the water is going to be drawn out of the intercellular and interstitial compartments into the plasma and the blood, and then that's just going to go get excreted. Okay, so let's say this is mannitol. I am mannitol roaming around here. I'm going to be sucking out the water in the interstitial tubules, and it's going to go into these tubules out all the way to as urine. Okay. Now, when do you want to use this? The same thing as acetazolamide. You don't really use it for hypertension or like to diuresis. More often use it in most importantly elevated intracranial pressure. When you can have elevated intracranial pressure, usually it's going to be like a car accident. Someone's got in a car accident and trauma, or he has brain tumor or something. Okay. Why does that work? Because mannitol in the brain, it's gonna come along, it's gonna say, look, brain cells, give me all your fluid. The fluid's gonna go out of the brain cells, it's gonna go into the plasma, and then it's gonna go all the way into your urine. Okay. If you use that same logic here, intraocular pressure, same thing. It's going to suck that fluid out of the eyes and it's going to lead to diuresis. Now, extremely important is very, very important that it's contraindicated in heart failure. Why? So if you remember from CVP, heart failure, you're already overloaded. You already have a lot of fluid in your body, and your heart can't handle all this fluid. So what do you want to do in heart failure is that you want to kick out fluid. And okay, although mannitol will do that, but the way mannitol is going to do that is by first bringing in more water from the cells into the blood, into the plasma. And you don't want that because you're already overloaded in the plasma. Your blood is already overloaded. So if you do that, you're just going to bring in more blood and the heart can't handle that. And that's going to lead to pulmonary edema. Why? Because the fluid is going to back up from the heart into the pulmonary vessels and it's going to lead to pulmonary edema. So the same thing, you don't want to use it in pulmonary edema and or heart failure, okay? Because before it actually helps, it's gonna ruin these diseases first. Now, loop diuretics. It's like, okay, loop diuretics, they work here, the ascending loop of Henle, by inhibiting a receptor. What receptor is that? It's the sodium potassium 2 chloride cotransporter in the thick ascending loop, furosemide, loop diuretics. Loop diuretics is extremely important. You're always going to see it, okay? If it inhibits sodium, sodium is going to get kicked out and water is going to follow sodium. So you want to kick out sodium. Why? Because water will follow sodium. So when you want to use it, it's mostly used in heart failure. Okay, it's mostly used in heart failure because if you're kicking out the water, then there's going to be less, like I said, you're overloaded, your volume overloaded in heart failure. So less volume is what you want, and furosemide is the most fastest acting out of all these drugs in terms of doing that. So this is the most important high yield entity you want to know of when furosemide is used, okay? It can also be used in liver disease, kidney disease, and hypercalcemia very rarely. Why? Because it leads to decreased calcium, hypocalcemia. Side effects are extremely important for furosemide. Some of them are very unique, like ototoxicity. Ototoxicity, you have a very few drugs that can cause ototoxicity. Some of them are like aminoglycosides. Gentamicin can cause ototoxicity. Another class of drugs are loop diuretics. Furosemide can cause ototoxicity. So, like I said, it's unique. So that's what they're gonna ask you about. Okay, since it's unique. Hypokalemia makes sense. Why? Because if you look here, let's look at where loop diuretics are. Okay, this is loop diuretics right here. I'm going to kick out potassium as well. I'm kicking out potassium, not only sodium. So if I kick out potassium, it's going to lead to hypokalemia. Makes sense, right? Okay, that's a side effect. Hypomagnesemia is similar to hypokalemia. Now, hyperuricemia is also unique. You don't often have drugs that can cause hyperuricemia. Both thiazides and loop diuretics can cause hyperuricemia, okay? And hyperglycemia. So that's for furosemides. Okay, furosemides, this is how it works. Like I said, this is the ascending loop of Henle right here. So right here, ascending loop of Henle. It's it's going to inhibit this receptor. As a result, you're going to have sodium and potassium kicked out, and the water is going to follow it. But so are calcium and magnesium. That's why it can lead to hypocalcemia and hypokalemia and hypomagnesemia. Okay. Our next medication is hydrochlorothiazide. Now, thiazide diuretics are going to be similar to loop diuretics in that they inhibit a receptor, but the receptor is here. It's going to be in distal convoluted tubule, and it's going to be inhibiting the sodium chloride. Okay, only sodium chloride, not sodium potassium chloride. Sodium chloride, and the same thing. You inhibit sodium, water is going to follow sodium, and it's going to get kicked out. Okay. When is it used? In hypertension. Like any hypertensive guy, you know how they give him ACE inhibitors like lisinopril. They can also give them thiazide diuretics. Okay. Now something unique is that it can also be used in calcium stones. Why? Why can it be used in calcium stones? Allow me to explain. Okay. Here are loop diuretics. Like I said, distal convoluted tubule, loop diuretics right here. Okay. Now, although it is inhibiting sodium and chloride, okay, sodium is going to get kicked out into the urine. At the same time, it's going to be reabsorbing calcium. Okay, it's also going to reabsorb calcium, and you're going to have calcium going into your blood. So it can actually lead to hypercalcemia. Now, how does that help with stones if you think about it? Like you might be thinking, wait, Omar, if it's going to lead to hypercalcemia, won't that lead to worsen stones? No. The idea is that The stones are created in the tubules, not in the cells in the blood. It's created in the interstitial, like the tubules right here, okay? Where your urine comes out of, okay? So if you have so much calcium here, like here, if there's a lot of calcium here, all that calcium is gonna, group up together and gonna create a stone. So how do you avoid that? By bringing in some calcium into the blood, by bringing in some calcium into the blood. Okay, so that's why calcium is helpful for patients with stones, calcium stones, as well as those with hypocalcemia, because it can reabsorb calcium. Okay. Now for its side effects, hypercalcemia. Now this is very nice mnemonic. You can say hyper gluck. Okay, gluck. The G is for glycemia. The L is for lipidemia. The U is for uricemia, and the C is for hypercalcemia. So hypergluck. Okay, hypergluck. It's very easy. You'll always remember this, and it's very important. Okay. Also can cause hypokalemia. Hypokalemia is in both furosemide loop diuretics as well as thiazide diuretics. Very important. Okay, we'll see later why. And the exact reason why is because we also have potassium sparing diuretics. So these loop diuretics and thiazide diuretics cause hypokalemia to the point that they're like, listen, we need to make some drugs that doesn't cause hypokalemia. And those are your potassium sparing diuretics. So you have some things like these work here, of course, in the collecting duct. You have things like spironolactone, and then you also have things like here. Okay, you have, so here, how does spironolactone work, and what's the other drug? The other drug is amiloride trimethoprim. Okay, so there's two different ways of these drugs working. They essentially have very similar mechanisms of action, but two different ways. So one is that you can antagonize aldosterone altogether. Okay, you antagonize aldosterone. You make it not work, aldosterone. Or you let aldosterone work, but you prevent what aldosterone is meant to do, which is activate sodium channels. Okay, so let me explain it to you with this diagram. So here you have aldosterone. This is one. This is aldosterone, and this is its receptor. If you inhibit this, it means you're antagonizing aldosterone's effect, which is aldosterone receptor antagonists like spironolactone and eplerenone. Okay. However, you can let that happen, but you inhibit what it's going to lead to, which is the activation of these sodium channels. See, you're bringing in sodium. You don't want that to happen. You want to kick it out. So those are what epithelial sodium channel blockers, aka amiloride and trimethoprim do. Okay, so let's recap. Sodium channel block inhibitors, amiloride and trimethoprim, aldosterone antagonists, spironolactone and eplerenone. Okay, they work very similarly. You can read this. Okay. Now, these are potassium sparing, so they're not going to lead to hypokalemia. So if you're getting a lot of hypokalemia with these loop diuretics and thiazide diuretics, what you can do is you can bump in some potassium sparing diuretics, so you can keep some of that potassium. Okay. And now, obviously, it makes so much sense that if you're going to be sparing potassium, it can lead to hyperkalemia. So in fact, a side effect of this drug is that it can lead to hyperkalemia. Okay. Now, another unique side effect is spironolactone. Spironolactone has some anti-androgen effects, okay? Because anti-androgen effects. So what could that lead to? Gynecomastia, okay? Enlargement of the nipples and the tissue around it, mainly in men. Okay, gynecomastia, it can also lead to erectile dysfunction, decreased libido, etc. But that's only for spironolactone. So if you don't want that to happen, you can give eplerenone instead. Eplerenone will not cause these anti-androgen effects, okay? So spironolactone causes anti-androgen effects. Eplerenone does not cause anti-androgen effects, okay? It's also very important to remember that spironolactone is used in ascites, liver ascites mainly, okay? Spironolactone is used in ascites, okay? Not these other diuretics, ascites, spironolactone. So, and then you have, this is kind of less high yield in my opinion, ADH antagonist conivaptan. It's going to basically block antidiuretic hormone. So you're not going to be sucking in water. The water is just going to follow into your urine, okay? Decrease water reabsorption. It's used in syndrome of inappropriate antidiuretic hormone. Why? Because you're going to have a lot of ADH. So what do? You block the ADH, okay? That's why it can lead to nephrogenic diabetes insipidus. I don't know if you guys have learned this, but nephrogenic diabetes insipidus basically means that the ADH is not working, it's not acting at the kidneys. There is ADH, but it's not doing its function at the kidneys, okay? So let's recap. Let's recap here. So what do we have here? This is A, this is the proximal convoluted tubule. You can have carbonic anhydrase inhibitors. It's going to inhibit carbonic anhydrase, which is going to kick out bicarbonate. It's going to kick out bicarbonate, and it's going to lead to what? Acidosis, acidazolamide, okay? Mannitol also works here by sucking in the water. Remember, you don't want to use mannitol in heart failure or pulmonary edema. You want to use it in intracranial, elevated intracranial pressure and intraocular pressure, okay? B, this is where you use mannitol, osmotic diuretics, okay? C is loop diuretics. Remember ascending loop of Henle, you block sodium 2-chloride potassium. It's going to kick out sodium and potassium, leading to hypokalemia, but it can also lead to hypocalcemia and hypomagnesemia. What are the unique side effects of loop diuretics? Remember we said ototoxicity, hyperuricemia, hypokalemia, okay? And here on top we have the thiazide diuretics. So it inhibits the sodium chloride and at the same time reabsorbs calcium. So it can lead to hypercalcemia, but don't forget it also leads to hypokalemia. And then we just talked about the potassium-sparing diuretics. You either inhibit aldosterone altogether, or you inhibit the sodium channels that aldosterone activates. Aldosterone receptor antagonists, epithelial and sodium channel blockers. Okay. Now, enough of discussion. Let's dive into some questions. So you can pause the question, and because this is a recording, you can pause the question, and then we'll talk about it. Okay, so I'm assuming you read the question, and now you have an answer in your mind. So a 62-year-old man comes to the emergency point with severe shortness of breath, orthopnea. Okay, significant for myocardial infarction, elevated jugular venous pressure, crackles, and then chest X-ray shows pulmonary edema. Pulmonary edema. So basically, this guy has heart failure, exacerbated heart failure. And what did I tell you guys? The best drug for heart failure exacerbation is? Yes, you got it right. Loop diuretics. Loop diuretics. Where do loop diuretics works? I mean, common sense. Loop of Henle. So furosemide. You want to give furosemide for pulmonary edema and elevated and heart failure. Furosemide. Okay, and it works at the loop of Henle. Okay, listen. Chest X-ray shows pulmonary edema. There it is. Okay. And don't forget loop diuretics. What are the side effects of loop diuretics? We said ototoxicity. Okay, it has two O's. Ototoxicity in loop of Henle, ototoxicity, hyperuricemia, hyperuricemia, okay, and hypokalemia, most important ones. So that's the answer. Now let's move to the next question. Great, so I'm hoping you answered it. Make sure you pause, don't forget to pause. So, okay, cirrhosis and ascites. What did I just tell you guys? What is used for ascites on neurite directed? I told you guys, okay? And 2 weeks later, he presents with gynecomastia and breast tenderness. So this is what anti-androgenic effects. It is caused by what? Spironolactone. Remember, spironolactone is a potassium-sparing diuretic that acts as an anti-androgen, and it can lead to gynecomastia and breast tenderness. So if I say, what can I replace spironolactone with? I can replace spironolactone with eplerenone. Why? Because eplerenone does not cause these anti-androgen effects. Remember that, eplerenone, okay? Ascites. Remember, spironolactone is used in ascites, and it can lead to gynecomastia and breast tenderness. Okay, amiloride is what? It's a sodium channel inhibitor. Okay, it can lead to hyperkalemia. Hydrochlorothiazide is what? It is a thiazide diuretic. Thiazide diuretic can lead to hypercalcemia, hypokalemia, and then remember hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. Furosemide, we just talked about it, eplerenone. There it is, okay? So this is why E is wrong, because E does not cause gynecomastia and breast tenderness. Next question. Okay, so I'm hoping you paused this question and read the answer, and you have an answer in your mind. So a new improvement in his blood pressure, a new medication is started, and it leads to hyperglycemia and hypercalcemia. So which of these diuretics? Let's go one by one. Triamterene is a what? It's a direct sodium channel inhibitor in the collecting duct, and it leads to hyperkalemia. Spironolactone is a and aldosterone antagonist. It can lead to hyperkalemia and gynecomastia. Hydrochlorothiazide is a thiazide diuretic that leads to hyperglyc. Wait, what is hyperglyc? Hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. Okay, and then we have amiloride, which is similar to triamterene, and eplerenone, which is similar to spironolactone, except eplerenone does not cause gynecomastia. Good. So the answer here would be hydrochlorothiazide. Hydrochlorothiazide, where does it work? Hydrochlorothiazide works in thiazide directives in the distal convoluted tubule. It inhibits sodium and chloride channels. It leads to hypercalcemia and hyperglock. Great. Now, next question. So I hope you paused and answered this question in your mind. So let's see here. Let's see. Difficulty hearing. So the main complaint is difficulty hearing. She was admitted 1 week ago for pulmonary edema, which has been slowly improving with treatment. I wonder what drug they gave to treat pulmonary edema. That's a good question. Her family members report that for the past 2 days, she has been turning her TV volume higher and they have to speak louder for her to hear. What does that mean? It means that she has some problems with hearing, right? Difficult hearing. And this is less likely to be due to age. Why? Because it's just the past 2 days. I mean, it's not something that's been happening for years. It's sudden, it's acute. So it could be something related to a side effect of something, right? Her hearing was normal prior to hospitalization. So heart failure, okay, shows moderate bilateral sensorineural hearing loss. That's even more proof that there is difficult hearing. So which of the following medications from these medications could have caused hearing impairment? ACE inhibitor, not really. It causes cough. Acetazolamide, what did we say? Acetazolamide causes acidosis. So this is not a side effect. Furosemide, what is furosemide? Furosemide is a loop diuretic, so it can cause ototoxicity. Ototoxicity, okay? Loop diuretics cause ototoxicity. So this would indeed be the answer. Furosemide is the answer because this patient is having decreased hearing due to ototoxicity, and that is the answer. Okay, we already went through spironolactone multiple times. So next question. I hope you answered the question. So high altitude acute mountain sickness. There's literally only one medication from the diuretics that can be used in acute mountain sickness. And I hope you're telling me acetazolamide inhibitors, which the answer is A, inhibits carbonic anhydrase in the proximal tubule, leading to bicarbonate diuresis, like we said right over here. Okay, right over here, carbonic anhydrase inhibitors. It inhibits carbonic anhydrase, leading to a kicking out of bicarbonate, which can lead to acidosis, and somehow it helps with acute mountain sickness. Okay, this is the next question. So, adding chlorothalidone, which of the following metabolic effects may be expected as a result of adding chlorothalidone? What is chlorothalidone? Chlorothalidone is a thiazide diuretic. What did we say thiazide diuretics side effect is? Hypergluck, hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. Hypergluck, chlorothalidone hypergluck. Okay, great. So hyperglycemia, decreased lipids, it's the complete opposite. Hyperkalemia, no, it causes hypokalemia. Hypernatremia, no, it causes hyponatremia. That's why it works, and it does not cause hypocalcemia because it causes hypergluck, which and the C is calcemia, hypercalcemia. Great. So these are some other mnemonics. So mannitol moves water. Okay, mannitol sucks the water out of your brains. Okay, and also your heart, the lungs. Okay, that's why it's used in elevated intraocular pressure and elevated intracranial pressure. Acetazolamide. Okay, remember acidosis. Now the potassium stays. This is a new one. Okay, so potassium sparing diuretics can be remembered as the potassium stays. S is for spironolactone, T is for triamterene, A is for amiloride. But don't forget eplerenone. Okay, so spironolactone, triamterene, amiloride. These the potassium stays. Okay, and of course my favorite hyperglock. Okay, next. So don't forget this. Okay, this is my table if you want to review it real quick. And now on to the next immunosuppressants. So this is the immunosuppressants table I created. The most important three drugs are going to be these three drugs: cyclosporin, tacrolimus, and sirolimus. Mycophenolate, you guys have taken, I think you guys learned before, belatacept and basiliximab, not as high yield as these three bangers. Okay, so cyclosporin and tacrolimus are calcineurin inhibitors. Calcineurin inhibitors. Okay, what are calcineurin inhibitors? So this is cyclosporin. Okay, so this here right here is calcineurin. Okay, you can see calcineurin right here. Calcineurin will bind to calmodulin. CM is calmodulin. Calmodulin will bind to calcineurin, and that's going to lead to dephosphorylation of N-fat. So dephosphorylation of N-fat makes N-fat active. Okay, N-fat is gonna be pretty hungry, you know. So N-fat is gonna go into the nucleus, and it's gonna transcribe inflammatory factors. It's gonna transcribe cytokines like what? Interleukin 2, interleukin 2, interleukin 2. Okay, interleukin 2 is not nice. We want to inhibit interleukin 2. Okay, so how do you inhibit this? You want to prevent N-fat from being dephosphorylated. How do you inhibit N-fat from being dephosphorylated? By inhibiting this calcineurin-calmodulin complex. And that's what cyclosporin does. Cyclosporin comes, it tells calcineurin, you know, screw yourself. I'm not gonna let you dephosphorylate N-fat. Okay, I'm not gonna let you lead to the production of IL-2. Okay, cytokine production. So cyclosporin is going to bind to this, okay? And it's going to prevent this from activating, okay? Let's go back so we can read. Calcineurin inhibitor binds cyclophilin, inhibits T cell activation. Inhibits T cell activation by how? By blocking IL-2 transcription. Blocking IL-2 transcription, okay? Tacrolimus is going to work in a similar way. It's also a calcineurin inhibitor, but instead, tacrolimus is going to be, it's going to bind to something else called what? FKBP. FKBP. FK binding protein. Okay, FK binding protein, and then the same thing is going to inhibit calcineurin and is going to prevent the dephosphorylation of N-fat, which is going to lead to decreased IL-2 production. So both of them have a very similar mechanism of action. They inhibit calcineurin, leading to the prevention of IL-2 production. Okay. Two extremely important side effects are nephrotoxicity. Nephrotoxicity. Why is that important? Because cyclosporin and tacrolimus are actually most commonly used in, and I think so, in renal transplant. So imagine you're giving a guy a new kidney, but then you're giving him a medication that is nephrotoxic. So that's why you want to be very careful, okay? Now, cyclosporin can also cause hyperkalemia and gum enlargement. Hyperkalemia, like what? Like your potassium-sparing diuretics. Ooh. Okay, now we have a third drug, sirolimus. Okay, now sirolimus is, instead of preventing the production of IL-2, sirolimus is going to let IL-2 work. It's going to let IL-2 be produced, but it's not going to let IL-2 bind to T cell and activate T cells. So T cells won't respond to IL-2. You see the difference? So tacrolimus and cyclosporin, they prevented IL-2 from being produced, but sirolimus prevents IL-2 from activating the T cells, okay? So extremely important thing here as well, a very high yield, is that it's non-nephrotoxic. I don't know how important I can make this any, let's see, yes, that's exactly what I want. Non-nephrotoxic, okay? So why? Because if a guy gets nephrotoxicity from these drugs, you can just give them sirolimus instead. If a guy or a woman, sorry, I don't want to be, whatever. Okay, so that's the main three drugs that we want to talk about here. Remember the two differences between this, okay? So this is mTOR inhibitor. It also binds FKBP here as well, FKBP, but this prevents IL-2 from activating T cells, while here this prevents the production of IL-2. This prevents the milk coming out of the cow directly, and this prevents, like the milk working on a human being or whatever. Okay, now you have mycophenolate mofetil, which they also call, MMF. Okay, this is, I mean, I don't know. You just gotta memorize this. Inhibits inosine. Damn. Okay, and it inhibits IMP, which prevents guanine synthesis. And guanine is an amino acid. Is it? Is it an amino acid? I don't know. It is. I don't know. I forgot. Whatever. Okay, you need guanine for lymphocyte proliferation. If you prevent guanine synthesis, lymphocytes can't proliferate. these T cells will not proliferate, and then we'll have some immunosuppression. Okay, why? Because immunosuppression basically means inhibiting T and B cells. Okay, why? Why do you want to inhibit these T and B cells? Because you don't want there to be graft rejection. What is graft rejection? That's a transplant rejection. Okay, transplant rejection, transplant rejection. Okay. Um, Side effects, pancytopenia. Why? Because you need guanine for regular, T cells, B cells, and stuff like that. So it can lead to pancytopenia. It is teratogenic. Okay. So now you also have belatacept. This is like the first time I hear this in my life. You're never going to see this in your life, probably. But anyways, it binds to CD80, CD86 receptors on antigen-presenting cells, preventing co-stimulation of T cells. Now, I think, in my opinion, you did not understand a single word of this sentence. So allow me to explain, okay? So this is belatacept. Now, this is an antigen-presenting cell. It can be a dendrite, it can be whatever, okay? And this is your T cell. You don't want this T cell to be activated. You hate T cells. You are T cell phobic, okay? Uh, so why? Because T cells can cause rejection, right? Okay. Now what you do? So this is extremely important. Like this is gonna be a throwback to what's that guy's name? Darwin. No, what's his name? Darwin. Anyways, so this signal MHC is gonna bind to the T cell receptor. It can be CD3, CD4, CD8, whatever, and that can activate T cells, right? This is literally common sense. Like this is kindergarten. If you don't know this, I don't know. Okay. Now, this is not the only thing you need to activate T cells. There's also another signal you need to activate T cells. It's called the CD80, CD86, binding to CD28. You also need this signal to essentially activate the T cell. So what you can do is that you can prevent this signal from being activated. Now, what you should need to remember is that CD28 is on the T cell, whereas CD80/CD86 is on the antigen presenting cell. So belatacept is going to come, it's going to be like a third party, um, a third wheel or whatever you call it. It's just going to prevent CD80 and 86 and CD28 from having some interaction, which is going to prevent the T cell from being activated. Okay, so like I said, the main thing you want is immunosuppression by preventing activation of T cells, etc., etc. Now you also have basiliximab. So basiliximab, it comes back to IL-2. I don't know why everyone hates IL-2 here. Okay, cyclosporin, everyone hates IL-2. So what basiliximab is going to do is that it's going to prevent IL-2 from binding to its receptor. Okay, so remember, cyclosporin and tacrolimus was preventing the transcription of IL-2. Sirolimus was preventing IL-2 from activating T cells. Now basiliximab is going to prevent IL-2 from binding to its receptor, like right here. This is CD25 on a T cell. This is IL-2. You don't want IL-2 to bind to CD25, so basiliximab is going to come in and be like, hey, you can bind to CD25. Okay, great. So I hope that was easy. That's it for my session. Wait, we have some more questions. Yeah, okay, so I hope you can pause and we can continue. Okay, so underwent kidney transplantation. When you undergo kidney transplantation, you want to prevent graft rejection, so you give immunosuppressants. Okay, 1 month later, he presents with elevated creatinine and hypertension. What does elevated creatinine mean? I mean, you're taking the nephrology block, so I hope you know what that means. It means this guy's going into like kidney disease, chronic kidney disease. Okay, so which one of these can cause chronic kidney disease? I hope you remember that tacrolimus is nephrotoxic. Tacrolimus nephrotoxic. Tacrolimus and what? Cyclosporin. So this is the same question. This is the same scenario, but it says which of the following medications should he be switched to? You want to switch this guy to something that's non-nephrotoxic, which is, I hope you remember, the answer is sirolimus. Okay, so tacrolimus and cyclosporin are nephrotoxic. Sirolimus is not nephrotoxic. Tacrolimus and cyclosporin are calcineurin inhibitors. They prevent the transcription of IL-2, whereas sirolimus is prevents the IL-2 transduction signaling with T cells. Okay. Oh, that's it. That's it for this session. Okay. Now let's go on to benign and malignant prostatic diseases. So this is my my summary table, of course. No one else created this. So, okay, so the main thing here is that you have benign and malignant prostatic diseases. Now, which disease is benign? You're talking about benign prostatic hypertension, BPH. Malignant is literally prostate cancer. So we're going to be talking about medications that can prevent BPH and cancer disease, okay? Prostate cancer. So the main idea you want to remember for BPH, now we're going to be talking about BPH first. Let's talk about benign prostatic hypertension first, is that you have alpha-1 adrenal receptors everywhere. Okay, now the main two areas are the prostate, bladder neck, as well as the peripheral vasculature, which means basically your blood vessels, your arteries, your capillaries, or whatever. Okay, so if you remember that you can, if you activate these receptors, it's going to lead to what? Vasoconstriction. If you inhibit these alpha-1 beta receptors, it's going to lead to vasodilation. Okay. Now, if you inhibit the alpha-1A receptors, it's going to lead to what? Prostate and bladder neck muscle relaxation. Remember what I say, muscle relaxation. Okay. And make sure you know the pathophysiology of BPH. BPH leads to enlargement of the prostate and the transitioning zone. I think transitioning zone, double check that. And as a result, it's going to be harder for a guy to pee. And mainly in elderly men, it's going to be more difficult in the urine from leaving the bladder into the urethra. Okay. So there are two ways to help with that. The two ways are that either you can cause smooth muscle relaxation of the prostate and bladder neck. If you relax the muscle, there's going to be more space for the urine to go through the urethra. That's number one. Or number two is that you can reduce the prostate size. Instead of just making it relax, reduce the prostate size, make it smaller, prevent it from blocking the pathway of urine to go outside. Okay. So that's the two drugs, that's the two mechanisms of action you have. Okay. Either by making it relax or by reducing the size. Okay. That's the two things for BPH. Now let's talk about alpha-1 adrenergic antagonists, alpha blockers. Okay. So you either have selective ones, which means that they're only going to bind to this, or you have non-selective ones, which means they're going to bind to both. They're going to bind to everything in the body, and they're going to bind to both of these and cause antagonism. Okay. Now, if you bind to, if you bind to everything and antagonize both the vasculature and the prostate, what is that going to lead to? Just think about it. You're antagonizing the peripheral vasculature. That's going to lead to vasodilation. Vasodilation might lead to hypotension and also lead to orthostatic hypotension, which means that when you stand from a seated or laying down position, you feel hypotensive and dizzy. Okay. So non-selective alpha adrenergic antagonists are going to antagonize this as well and lead to dizziness and hypotension. That's why I tried to make up a mnemonic for you guys, which is called dizzy terazocin, which means doxazocin and terazocin cause dizziness. Why? Because they are non-selective. Now, I know you also have tamsulosin here, which is with a T. Terazocin and tamsulosin are with T's. So in order to remember the mnemonic, you want to use dizzy terazocin, and everything else is going to be selective. So dizzy terazocin is non-selective. Everything else is selective. Okay, remember that. Remember it that way. Now, what did we say? It blocks alpha-1 receptors. Okay, so dizzy terazocin is going to lead to orthostatic hypotension, but everything else is not going to lead to hypotension, okay, and dizziness. So that's the first thing you have. Now, before I talk about 5-alpha reductase inhibitors, PTE inhibitors are actually very similar to these big guns here, so the alpha-1 adrenergic antagonists, in that they also cause relaxation of the smooth muscle. By how? By inhibiting PDE and increasing CGMP levels. This is extremely important, unfortunately. When you increase the CGMP levels, okay, it causes dilation and relaxation of these things, okay? It causes relaxation of smooth muscle. Smooth muscle relaxation, how? By increasing CGMP levels. How do you increase CGMP levels? By inhibiting phosphodiesterase E5, like the tadalafil, okay? If you think about it, if both of these drugs, if the alpha-1 adrenergic receptors antagonists and the phosphodiesterase inhibitors are both causing relaxation, imagine you combine them together. If you combine these two drugs together, you're literally going to kill the guy. The guy is going to become extremely hypotensive and he's going to faint and he's going to become extremely dizzy. So what's the lesson for today is that you do not want to combine these two drugs together. You never want to combine them. Why? Because it's going to lead to severe hypotension. Okay. Now, so we said that we can cause relaxation of the muscle. And the second way was by what? By reducing prostate size. How do you reduce prostate size? By giving 5-alpha reductase inhibitors. What is 5-alpha reductase? 5-alpha reductase causes the conversion of testosterone to dihydrotestosterone. And dihydrotestosterone causes an increase in prostate size. So you do not like dihydrotestosterone. You don't want more of dihydrotestosterone. So how do you do that? By inhibiting alpha reductase, 5-alpha reductase, okay? You inhibit 5-alpha reductase, you prevent the conversion of testosterone to dihydrotestosterone. Less DHT means smaller prostate size. What are examples of 5-alpha reductase inhibitors? Finasteride and dutasteride, okay? Now, an important thing is that these guys can lead to erectile dysfunction, decreased libido. Okay, these are extremely important side effects. Why? Because you have less of DHT. Okay. So now, if you use some common sense here, you can think that, hey, why don't we cause smooth muscle relaxation and reduce the prostate size? We do two in one. Why don't we do both of them? And that's exactly correct. We can combine alpha-1 adrenergic antagonists with 5-alpha reductase inhibitors, combine these two guns together so we can do two effects. So we can reduce the prostate size and we can cause smooth muscle relaxation to ultimately lead to increase in urine outflow. Okay, so that is for BPH. Now let's do some questions for BPH. You can read this. Okay. So 1 week later, he's diagnosed with benign prostate hypertension and started on a medication. 1 week later, he returns to the clinic complaining of dizziness and feeling lightheaded. What does that mean? It means that he was given dizzy-terrazosin. Oh no, he was given dizzy-terrazosin. Let's go back. He was given dizzy-terrazosin. Okay, dizzy-terrazosin. So, over there. Okay, dizzy-terrazosin. So where is dizzy? Doxazosin and dizzy-terrazosin. Everything else is going to be what? Non-selective. So tamsulosin is non-selective. Tamsulosin is selective. Alfuzosin is selective. Selective, non-selective. This is non-selective. And the answer is C. Oh, wow, I give some explanations here. Okay, great. So doxazosin, dizzy-terrazosin. Okay, you can read this yourself if you want. Next question. So you inhibit the conversion of testosterone to dihydrotestosterone. Which of the following side effects is most likely to occur? First of all, which drug is this? This drug is finasteride or dutasteride. Finasteride. They are 5-alpha reductase inhibitors. The enzyme is 5-alpha reductase. The mechanism of action is converting testosterone to dihydrotestosterone. If you inhibit it, you prevent this from happening. And those drugs are finasteride and dutasteride, okay? I hope I'm not muted. Okay, I'm not muted, great. So what is the side effect? Erectile dysfunction. Nephrotoxicity was what? Remember, cyclosporin and tacrolimus. Hyperglycemia was what? Hypergluck. It was a thiazide diuretics. Hypokalemia was what? Thiazide diuretics and loop diuretics. Okay. So I think, yeah, there it is. Now let's think. Now let's move on to these drugs. So these drugs are going to be for malignant diseases, malignant prostatic, like malignant cancer diseases, like what? Like prostate cancer. Now, in conclusion of the pathophysiology of prostate cancer, is that it is due to it can sometimes be due to elevated hormonal levels of like testosterone or something, why? Because testosterone causes a growth of the tumor. So what do you want to do? You want to prevent testosterone and androgens so you can shrink the size of the tumor, okay? So you have a few mechanisms of doing that. So you have a few mechanisms of preventing testosterone from doing its work. Now, let's start from the top. You have hypothalamus, gonadotropin receptor hormone activates the anterior pituitary to lead to LH and FSH. LH and FSH will activate the gonads and like the to produce testosterone, right? So in order to help with prostate cancer and inhibit decreased testosterone, you can affect any one of these junctions, right? You can affect any one of these sites, and that's exactly what these drugs are all about. So these drugs, it can either be GnRH affecting, or it can be directly related to the androgen synthesis. Okay. So first we have leuprolide, GnRH agonist. Now this is a very unique mechanism of action. What it's going to do is it's going to continuously stimulate GnRH receptor. It's going to continually stimulate this guy. It's going to continually stimulate GnRH receptors. Okay. And you're going to be thinking like, wait, Omar, isn't that going to lead to increased LH and FSH? That is right. But over time, because you stimulated the pituitary so much, that خلاص they're going to get too used to it and they're going to get overstimulated, they're going to get burnt out, and there's going to be a decrease in the number of receptors. And as a result, there's going to be no more LH and FSH production. Why? Because they're not responding to GnRH anymore. You activated it so much that خلاص, they're not going to respond to GnRH anymore. Like you screwed up by giving too much attention. You know what I mean? So that's the conclusion of GnRH agonists. Is they give continuous stimulation of GnRH receptors, and that's going to lead to a downregulation of LH and FSH secretion, which is going to reduce testosterone production. Now, they have a unique thing called flare phenomenon, which is exactly what you just thought about. You just asked me, Omar, won't it lead to increase in LH and FSH? And that is right. It can initially acutely lead to increased LH, FSH. As a result, you're going to have elevated testosterone. So acutely, you can have worsening of the disease. You can have a flare up. You can have a flare up of the disease. Why? Because acutely you're leading to an increase in the LH and FSH, and that is called what? What is it called? Flare phenomenon. Flare phenomenon. Why? Because you led to a acutely increase in these hormones. Okay. So that's leuprolide for you, leuprolide. Now, instead of continuously activating it, how about we just like inhibit, we antagonize the receptor? How about we just antagonize the receptor? We prevent GnRH from activating the anterior pituitary. Why don't we do that? And that is exactly what digarelix, or I mean, how do you even pronounce this? Digarelix. Yeah, digarelix, that's exactly what it does. Okay. It's going to inhibit the GnRH receptor. So you're going to antagonize this receptor. It's going to prevent GnRH from activating this receptor. And unlike leuprolide, you're not going to have a acute increase in LH, FSH, and testosterone levels. So you are not going to have the testosterone flare. You are not going to have the testosterone flare, unlike leuprolide. Okay, great. Now, we've been talking about GnRH the whole time. We said we can either antagonize the hell out of it, or we can agonize the hell out of it. Okay. What about like testosterone production directly? Like, what about, why don't we just like mess up some testes or something, you know? And that's what androgen synthesis inhibitors are. So you have two different ways of doing this. You can either prevent the synthesis of androgens, or you can antagonize the receptors. So you have androgens, but you don't let it bind to the receptor. Okay. So what am I saying? It says that you can either, like, I want to zoom in as much as possible so you can focus on the male testes. You can either inhibit the synthesis of the androgens in the testes, or in the adrenal glands, because remember, androgens are also made in the adrenal glands. And that's going to be what? It's going to be androgen synthesis inhibitor, androgen synthesis inhibitor. Or you can be like, hey, let the testes create some testosterone, but I'm going to come and I'm going to prevent the testosterone from activating the receptors. And that is competitively inhibits androgen binding to receptors, preventing testosterone action. Okay. So you can either inhibit the synthesis, or you can inhibit the binding of the androgen. Okay. And those are the two drugs, abiraterone and apalutamide. Okay. It's extremely hard names. I apologize in advance. Okay, so let's move on to some questions. So a guy is treated with cancer, is treated with a drug to treat his cancer. However, he experiences worsening bone pain and increased PSA levels. PSA is prostate-specific antigen. It's like, wait, you just screwed over the disease even more. Why? Because of the flare phenomenon. Remember the flare phenomenon? It was because the flare phenomenon was because we were activating the GnRH receptors and we led to an increase in the LHFSH flare phenomenon, okay? So the answer is going to be what? Leuprolide, 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 okay? Great. See? Great. It does not happen with Digarelix. It does not happen with Digarelix. And then what is abiraterone and aplumetide? These are directly related to androgen synthesis and activation. Okay, next question. So this is a question from your past papers. So I don't know. I hope the answer is right there. Okay, the answer is C. Why is it dutasteride, and why is it not like one of these anti-cancer drugs? Now, first of all, his symptoms are typical of BPH. You know, decreased urination, feeling of urgency. He doesn't really have like cancer symptoms like a loss of weight, bone pain, stuff like that. And another thing that extremely important is that look, 1 year ago his serum post PSA was 6. 1 year later, his PSA is still the same. It has not increased. If it increased by a lot, it would make you think of cancer. But because it didn't increase, because it's the same, you might be thinking, oh, this is more likely to be a benign disease, which is BPH. And they just want you to know that the most effective treatment is by decreasing the size of the prostate, which is dutasteride, 5-alpha reductase inhibitors. Okay, it is not doxazosin or sildosin. The most effective drugs are the 5-alpha reductase inhibitors in BPH. Okay. Great. So let's quickly recap. So we have alpha 1 adrenergic antagonists. They can be selective, which won't cause orthostatic hypotension, or they can be non-selective and bind to the blood vessels as well and cause hypotension. Remember, you never want to combine PDE inhibitors with alpha 1 adrenergic antagonists. Okay. And then remember, these are the best drugs in treating prostate cancer, BPH, sorry, BPH. Okay, now also remember these GnRH agonists. You can either mess up with GnRH or the androgen synthesis. Okay, so GnRH you either continuously stimulate it, which can lead to a flare phenomenon, or you do not continuously stimulate it, and that's going to be Digarelix. And then remember the enzyme is important. CYP17 is the enzyme. Okay, it is related to androgen synthesis. So now we are left with the last lecture, and honestly, I'm going to be honest. This lecture is kind of like I think it's you're not going to get too many questions on it. You know, I'll just try to explain the things that might be very high yield. Now, first of all, look, renal disease it's common. Okay, why is it common? Because diabetes and hypertension leads to the renal disease, and diabetes and hypertension is common. You see a lot. You know, some families have a lot of families have it. It runs in the families, and it can lead to chronic kidney disease. So if you have a guy like wanting painkillers with chronic kidney disease, you can't give him NSAIDs. You can't give him like ibuprofen. Why? Because that's gonna mess up his kidneys. Because the kidneys filtrate a lot of these drugs. A lot of drugs are filtrated by the kidneys. The kidneys are the one that excrete them. So some of these extremely important drugs are like aminoglycosides, like gentamicin, amikacin. These aminoglycosides are extremely important. They can cause kidney disease as well as vancomycin as well. Okay, so these they are cleared by the kidneys. So if your kidneys are not working properly, you need to adjust the dose of these kidneys. Okay, so this is a picture from the lecture. Some of you guys understand. So this is plasma clearance. Okay, plasma clearance basically means it's getting kicked out of the blood into the urine. Okay, we can say something like that. And this is the GFR. As the GFR increases, it's the GFR is normal, right? Because the higher the GFR, the more normal it is, right? So let's say a GFR of 90 is here and a GFR of 15 is here. And this is the amount of drugs you're kicking out of the kidneys, okay, related to the GFR. So as the GFR increases, both gentamicin and cloxacillin are being cleared out more. They're being cleared out of the drug. What does that mean? It means that cloxacillin and gentamicin are being cleared by the liver, by the kidneys. Okay, by the kidneys, by the kidneys. The kidneys are the ones that are clearing out uh, um, cloxacillin and gentamicin. Why? because as GFR increases, there's an increased clearance, okay, which correlates to decreased level of these drugs in the plasma. Okay, that's a correlation. On the other hand, doxycycline, it doesn't matter. No matter the GFR, whether it's low or whether it's high, doxycycline's clearance is not affected. What does that mean? It means that the doxycycline is not cleared by the kidneys because it doesn't matter other the GFR, it doesn't matter if it's low or high, if the kidneys are working or not, it doesn't matter for the doxycycline, okay? So doxycycline is cleared by the liver. Okay, so gentamicin, remember, it's a very dangerous drug in what's it called? In kidney disease, also cloxacillin, dangerous drugs. So if a guy has an infection, if a guy has an infection like this guy, he has an infection, skin infection, but his creatinine is raised, what can you give him? You can give him doxycycline. Why? Because doxycycline is not affected by the kidney. However, cloxycycline and cloxacillin and gentamicin, because they're not going to be cleared, it can lead to increased levels, which can lead to toxicity and overdose. Okay. So yeah, that's it. These are some extremely important drugs you want to remember that are cleared by the kidneys. So aminoglycosides, vancomycin, digoxin, opioids, antibiotics. Okay, and not all of them, of course. And that's the conclusion. So this is if you remember, this is the way aldosterone antagonists and sodium channel inhibitors work for diuretics. These are some pictures from UWorld. I highly recommend you do some UWorld and Ambos. They're one of the best resources for studying compared to doing like highlighting the whole book. Okay. Side effects of the effects on total body electrolyte levels. Okay. Some summaries for you guys. Some more summaries for you guys. And yeah, that's it. Thank you very much for tuning in. If you have any feedback, positive or negative, please provide me feedback on this QR code. And if you have any questions, you can feel free to message me. Like for real, if you want to like email me or message me or whatever you want, just I'll be very happy to help you. So thank you very much and good luck. Allah يوفقكم إن شاء الله. إلى اللقاء.